Hello class, this is Emergency Care and Transportation of the Sick and Injured, Chapter 10, dealing with Airway Management. Upon completion of this chapter and your related coursework, you will understand the need for proper airway management, including recognizing and measuring adequate and inadequate breathing, maintaining an open airway, and providing artificial ventilation. You will also be able to demonstrate basic competency in applying these concepts with appropriate care through the use of airway adjuncts, suction equipment, oxygen equipment and delivery systems, pulse oximetry, continuous positive airway pressure, which is called CPAP, and resuscitation devices. The single most important step in caring for patients is to address life threats, and a primary component of that step is to ensure that they can breathe adequately. When the ability to breathe is interrupted, oxygen delivery to tissues and cells is compromised. Cells require consistent oxygen supply of oxygen to survive. And within seconds of being deprived of oxygen, vital organs such as the heart and brain may not be functioning normally. Brain tissue will begin to die within 4 to 6 minutes without oxygen. Oxygen reaches body tissues and cells through two separate but related processes, breathing and circulation. During inhalation, oxygen moves from the atmosphere into the lungs. Oxygen then crosses the alveolar membrane and attaches to hemoglobin by a process called diffusion. Red blood cells carry the hemoglobin and therefore oxygen through the body, ultimately delivering it to the capillaries to oxygenate body cells. At the same time, carbon dioxide produced by the cells and the tissues of the body moves from the blood into air sacs by diffusion. Oxygen-rich blood is pumped through the body by the heart. Carbon dioxide leaves the body during exhalation. As an EMT, you must be able to locate the parts of the respiratory system, understand how it works, and recognize which patients are breathing adequately and which are not. Let's discuss the anatomy of the respiratory system. The figure on this slide shows the upper and lower airways of the human body. The respiratory system consists of all the structures that make up the airway that help us breathe or ventilate. The airway is divided into the upper and lower airways. The structures that help us breathe are the diaphragm, chest wall muscles, accessory muscles of breathing, nerves from the brain, and spinal cord to those muscles. Ventilation is the exchange of air between the lungs and the environment. The diaphragm and the chest wall are responsible for the regular rise and fall of the chest that accompany normal breathing. The anatomy of the upper airway consists of all anatomic airway structures above the vocal cords. Again, this is the upper airway. Above the vocal cords, this is the nose, mouth, jaw, oral cavity, pharynx, and larynx. The pharynx is the muscular tube extending from the nose and mouth to the level of the esophagus and trachea. It is composed from top to bottom of the nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is lined with ciliated mucous membranes that filter out dust and small particles. It warms and humidifies air as it enters the body. The oropharynx is the posterior portion of the oral cavity. The epiglottis is superior to the larynx. This helps prevent food and liquid from entering the larynx during swallowing. The figure on this slide shows the anatomy of the oral cavity. The larynx is the complete structure formed by many independent cartilaginous structures. There are marks where the upper airway ends and the lower airway begins. The thyroid cartilage forms a V shape anteriorly, which is called the Adam's apple, and it is present on males and females. It's just less pronounced on females, but everyone has this thyroid cartilage V-shaped structure. The cricoid cartilage, or cricoid ring, forms the lowest portion of the larynx. The crithyroid membrane is the elastic tissue that connects the thyroid superiorly to the cricoid ring inferiorly. Remember, superior is front, inferior is back. The glottis or glottis opening is the area between the vocal cords. This is the narrowest part of an adult's airway. The vocal cords are white bands of thin muscle tissue. They're partially separated at rest, produce speech, and protect the trachea from entry of substances like water and vomitus. The thyroid cartilage forms a V shape anteriorly, the Adam's apple. The cricoid cartilage, also known as the cricoid ring, forms the lowest portion of the larynx. The glottis or glottis opening is the area between the vocal cords. This is the narrowest part of an adult's airway. The lower airway's function is to deliver oxygen to the alveoli. The lower airway includes the trachea, bronchi, and lungs. The trachea is the conduit for air entry into the lungs. It begins directly below the cricoid cartilage or cricoid ring. It descends anteriorly down the midline of the neck into the thoracic cavity. In the thoracic cavity, the trachea divides at the carina into two main stem bronchi, one for the right lung and one for the left lung. The bronchi are supported by cartilage. They distribute oxygen to the two lungs. The lung tissue is covered with visceral pleura, which is a slippery outer membrane, and the parietal pleura lines the inside of the thoracic cavity. This provides lubrication and also attaches the lung to the inside of the chest wall. On entering the lungs, each bronchus divides into ever small bronchi, which divide into bronchioles. These bronchi deliver oxygen to the lungs, or distribute it to the lungs. The figure on this slide shows the trachea and lungs into the lower airway, and you can see where the trachea begins, and there's the carina in the center, which gives a bronchi for right lung and left lung. And then it shows the distribution of main bronchi, smaller bronchi, and bronchioles. Bronchioles are made of smooth muscle, and they dilate and constrict as oxygen passes through them. Smaller bronchioles are connected to alveoli. This is the level where oxygen and carbon dioxide are exchanged. Alveoli are millions of thin-walled, balloon-like sacs. Alveoli are surrounded by blood vessels, which are called pulmonary capillaries. The oxygen diffuses across the alveolar membrane into the pulmonary capillaries. The oxygen in the pulmonary capillaries is transported back to the heart and distributed to the rest of the body. Carbon dioxide, or waste from cells, diffuses from the pulmonary capillaries into the alveoli, where it is exhaled and then removed from the body. The heart and great vessels, the vena cava and aorta, are also present in the thoracic cavity and are important for respiration. The mediastinum is the area between the lungs, which contains the heart and great vessels, the esophagus, trachea, major bronchi, many nerves, and the phrenic nerve is also found in the thorax. This is an important structure of the nervous system, and this is the nerve that allows the diaphragm to contract, which is necessary for breathing to occur. Let's discuss the physiology of breathing. The respiratory and cardiovascular systems work together to ensure that a body has a constant supply of oxygen and nutrients and is delivered to all cells. Removal of carbon dioxide and waste products from the cells is the other function. The table on this slide defines ventilation, oxygenation, and respiration. The first of those we're going to talk about is ventilation. Ventilation is the physical act of moving air into and out of the lungs, which is necessary for oxygenation and respiration to occur. Inhalation is the active muscular part of breathing, where the diaphragm and intercostal muscles contract. The lungs require movement of the chest and supporting structures to expand and contract during inhalation and exhalation. Partial pressure is the amount of gas in air or dissolved in fluid, such as blood. It is measured in millimeters of mercury. The amount of gas in the oxygen or partial pressure that resides in the alveoli is 104 millimeters of mercury. Carbon and dioxide enter these cells, or alveoli cells, from the blood and cause a carbon dioxide partial pressure of 40 milligrams of mercury. Oxygenated arterial blood from the heart has a partial pressure of oxygen that is lower than the partial pressure of carbon dioxide in the pulmonary capillaries. The body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and blood are equal. The mechanism of ventilation can be illustrated here by using a bell jar. Inhalation in the chest expansion is the anatomic structures that you see on the left, and bell jar on the right, which is exhalation and chest contraction, which show the anatomic left, again on the left, and bell jar on the right. So inhalation, everything inflates. Exhalation, everything deflates. Inspiration is focused on delivering oxygen to the alveoli. Not all inspired air reaches the alveoli for gas exchange. Tidal volume is the measure of depth of breathing, the amount of air in milliliters that is moved into or out of the lungs during a single breath. The tidal volume for an average adult is 500 milliliters. The dead space is the portion of inspired air that fails to reach the alveoli. Basically what that means is the oxygen is roughly 21% in our atmosphere. When you breathe that in, you do not consume the entire 21%. That remaining oxygen that stays there is called dead space. So not all of the oxygen that you inhale is ingested into your lungs. With exhalation, it does not normally require muscular effort. It's a passive process. So the diaphragm and the intercostal muscles that contracted to draw in air then relax and decrease the size of the thorax overall. The smaller thorax compresses air in the lungs into a smaller space. The air pressure in the thorax is then higher than the outside pressure, so air is then pushed out through the trachea. Air can enter and leave the lungs only if it travels through the trachea. This is why clearing and maintaining a patent airway is so vital. Air can enter and leave the lungs only if it travels through the trachea. And again, as I said, this is why clearing and maintenance of a patent airway is so important. So you can see there's the air going in through the nose and through the mouth, down into the trachea, and then into the lungs. So the airway is your most important focus, even if they have no pulse. If they don't have an open airway, you're not going to get a pulse back. The regulation of ventilation involves a complex series of receptors and feedback loops that sense gas concentrations in the body fluids and send message to the respiratory center in the brain to adjust the rate and depth of ventilation. The body's need for oxygen is constantly changing. Failure to meet this need may result in hypoxia, which is an extremely dangerous condition. This is when the tissues and cells do not get enough oxygen, and if not corrected, patients may die quickly. For most people, the drive to breathe is based on pH changes in the blood and cerebrospinal fluid. Patients with chronic obstructive pulmonary disease, or COPD, have difficulty eliminating carbon dioxide through regular exhalation. Thus, they always have higher levels of carbon dioxide. This contention potentially alters their drive for breathing because the respiratory centers in the brain gradually adjust to accommodate higher levels of carbon dioxide. In patients with COPD, the body uses a backup system known as the hypoxic drive to control breathing. Use caution when administering high concentration of oxygen to patients who have COPD. However, high concentrations of oxygen should never be withheld from any patient who needs it. So you've really got to keep an eye on COPD patients and determine how dire their need for oxygen is at any given moment. But if you over-oxygenate a COPD patient, they'll go into respiratory failure. Patients with severe respiratory and or circulatory compromise should receive high concentration of oxygens regardless of their underlying medical conditions if they're faced with serious hypoxia or serious trauma. But use caution with COPD patients if they're not in a state of complete hypoxia or suffering from major trauma, then do not use high level of oxygen with them if they have minor respiratory distress. Early signs of hypoxia are restlessness, irritability, apprehension, a fast heart rate or tachycardia, and anxiety. Late changes of hypoxia are mental status changes, weak or thready pulse, cyanosis, and conscious patients will complain of shortness of breath or dyspnea. The best time to give a patient oxygen is before signs and symptoms of hypoxia appear. In the process of oxygenation, oxygen molecules go into the hemoglobin molecules in the bloodstream, and this is required for internal respiration to take place. However, oxygen does not guarantee that internal respiration is actually taking place. Ventilation without oxygenation can occur, for example, in places where oxygen levels in the breathing air have been depleted, such as in mines or confined spaces, or possibly high altitude. With respiration, this is the actual exchange of oxygen and carbon dioxide in the alveoli and in tissues of the body. Cells take energy from nutrients through a series of chemical processes known as metabolism or cellular respiration. Each cell combines nutrients and oxygen, producing energy and waste products, mainly water and carbon dioxide. External respiration or pulmonary respiration brings fresh air into the respiratory system, exchanges oxygen and carbon dioxide between the alveoli and blood in the pulmonary capillaries, and the surfactant keeps alveoli expanded, making it easier for gas exchange. So they're just blown up like millions of tiny balloons, literally. Internal respiration is the exchange of oxygen and carbon dioxide in the systemic circulatory system with the cells of the body at the alveolar level. The oxygen passes from the blood into the capillaries to tissue cells. Carbon dioxide and cell waste pass from the cells into the capillaries at the alveolar level, where they are then transported back into the venous system, back to the lungs. All cells need a constant supply of oxygen to survive. So time is critical. 0 to 1 minute, you already have cardiac irritability. 0 to 4 minutes, brain damage is not likely, but from 4 to 6 minutes, brain damage is possible. At 6 to 10 minutes, brain damage is very likely. More than 10 minutes, irreversible brain damage occurs. When there's enough oxygen, cells convert glucose into energy through aerobic metabolism. Without adequate oxygen, anaerobic metabolism takes place, which cannot meet the metabolic demands of cells. If this process is not corrected, all cells will eventually die. Now let's talk about the pathophysiology of respiration. The factors in the nervous system are the first thing we're going to talk about. These are chemoreceptors in the brainstem that monitor levels of oxygen, carbon dioxide, hydrogen ions, and the pH of cerebrospinal fluid and provide feedback to the respiratory centers. Ventilation perfusion ratio is mismatched. Air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. A failure to match ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. When ventilation is compromised but perfusion continues, blood passes over some alveolar membranes without gas exchange taking place. This results in a lack of oxygen diffusing across the membrane and into blood circulation. Carbon dioxide is not able to diffuse across the membrane and into the lungs and is instead recirculated within the bloodstream, which can lead to severe hypoxemia. Similar problems can occur when perfusion occurs across the alveolar membrane. It's disrupted. Factors that affect pulmonary ventilation. Maintaining the patent airway is critical, as I stated previously. The intrinsic factors that can cause airway obstruction are infections, allergic reactions, or unresponsiveness. For instance, if they're unconscious and their tongue falls into the back of their throat. Extrinsic factors that can cause airway obstruction are trauma or a foreign body in the airway. Factors that affect respiration. External factors such as atmospheric pressure and the partial pressure of oxygen in the ambient environment. Internal factors such as conditions that reduce the surface area in the lungs for gas exchange and consequently decrease the body's oxygen supply can lead to inadequate tissue perfusion, and this can happen with pneumonia, pulmonary edema, and COPD or emphysema. Circulatory compromise is what we're going to discuss next. The obstruction of blood flow to individual cells and tissues is typically related to trauma emergencies. This includes pulmonary embolism, simple or tension pneumothorax, open pneumothorax, which is called a sucking chest wound, hemothorax, and hemopneumothorax. Other causes of circulatory compromise are blood loss, anemia, hypovolemic shock, which is an abnormal decrease in blood volume. In other words, somebody's bleeding out or bleeding internally. Vascular dilatory shock, which is an abnormal increase in blood vessel diameter, decreasing blood pressure. In other words, the entire vaso system just dilates and blood pressure just plummets. Any patient suspected of being in shock, which is what I was just describing, should be treated aggressively to prevent further interruptions of tissue perfusion. Now this fits into your patient assessment. To recognize adequate breathing, unless you are directly assessing a patient's airway, you should not be able to see or hear the patient breathe. Signs of normal breathing for adults are 12 to 20 breaths per minute, a regular pattern of inhalation and exhalation, bilateral clear equal and long sounds with regular equal chest rise and fall, and adequate depth or tidal volume. Recognizing abnormal breathing. An awake, alert adult who's talking to you usually has no immediate airway or breathing problems. Always have supplemental oxygen and a bag valve mask or BVM or a pocket mask close at hand to assist with breathing if this becomes necessary. Signs of abnormal breathing are fewer than 12 breaths per minute, more than 20 breaths per minute in the presence of shortness of breath, which is dyspnea, irregular rhythm, diminished, absent, or noisy, auscultated breath sounds, and reduced flow of expired air at the nose and mouth. You'll also see unusual or inadequate chest expansion, resulting in reduced tidal volume, increased effort of breathing with use of accessory muscles, shallow depth or low tidal volume, skin that is pale, cyanotic, which is blue, cool or moist, and which is clammy. Skin is pulling in around the ribs or above the clavicles during inspiration. That's called retractions. A patient may appear to be breathing after the heart has stopped. These occasional gasping breaths are called agonal gasps. Chikes-Stokes respiration are often seen in patients with stroke or head injury. This is breathing with an increased rate of depth and respirations followed by apnea or lack of spontaneous breathing. Ataxic respirations have an irregular or unidentifiable pattern and may follow serious head injuries. Patients experiencing a metabolic or toxic disorder may display other abnormal respiratory patterns such as Kussmaul respirations. Kussmaul respirations are deep, rapid respirations commonly seen in patients with metabolic acidosis. Patients with inadequate breathing need to be treated immediately, and the emergency care is airway management, supplemental oxygen, and ventilatory support. Even though the patient may be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may still be compromised by several factors, such as high altitudes, poisonous gases including carbon monoxide, and some EMS services carry handheld carbon monoxide detectors, and enclosed spaces. A patient's level of consciousness and skin color are excellent indicators of respiration. Even though the patient may be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may still be compromised by several factors, such as high altitude, poisonous gases including carbon monoxide, and some EMS services carry handheld carbon monoxide detectors, or enclosed spaces. Patient's level of consciousness and skin color are excellent indicators of respiration. When assessing patients, consider proper oxygenation, which can be assessed by pulse oximetry. Oxygen saturation, which is abbreviated SpO2, is a measure of the percentage of hemoglobin molecules that are bound in arterial blood. A pulse oximeter measures the percentage of hemoglobin saturation and should be 98 to 100% while breathing in room air. Although no definitive threshold for normal values exists, an SpO2 level of less than 96% in a non-smoker can indicate hypoxemia. An SpO2 of 90% or lower generally requires treatment unless the patient has a chronic condition causing perpetually low oxygen saturations. Pulse oximeters can take as long as 60 seconds to reflect changes in a patient's oxygenation status. The time delay is important because a patient can develop respiratory insufficiency well before pulse oximetry values begin to decline. It is critical to monitor the patient and supplement the assessment with information from the pulse oximeter. Pulse oximetry is considered a routine vital sign and can be used as any part of a patient assessment, and you'll practice this in Skill Drill 10-1. Factors that can cause inaccurate pulse oximetry readings are hypovolemia, severe peripheral vasoconstriction from chronic hypoxia, smoking, or hypothermia, a time delay in detecting respiratory insufficiency, dark or metallic nail polish, dirty fingers, or carbon monoxide poisoning. Pulse oximeters do not replace a complete assessment. Pulse oximetry cannot measure the effectiveness of ventilation or provide information about the total cellular metabolism. To assess ventilation, you will need to measure end-tidal carbon monoxide levels. End-tidal CO2, or carbon monoxide, is measured by capnometry and capnography devices. Emergency medical care begins with ensuring an open airway. Rapidly assess whether an unconscious patient has a patent airway and pulse and is breathing adequately. Airway and breathing are two closely related but separate components. Adequate breathing does not always equal an adequate airway. So position the patient correctly. The supine position is most effective. Sometimes the airway must be opened and assessed in the position in which you find the patient, as in vehicle entrapment, for example. A patient found in the prone position or lying face down must be repositioned. Log roll the patient as a unit so head, neck, and spine will all move together without twisting. While care should be taken to avoid injury, remember that airway management always takes priority and should not be delayed when caring for patients with life-threatening conditions. Here's an example of unconscious patients that should be moved as a unit. And remember, once you get them on their back, the most common airway obstruction is the tongue. They also have risk for spinal injury. Other causes of airway obstruction are dentures, false teeth or partials, blood, vomitus, mucus, food, or other foreign objects. The head-chin lift maneuver will open the airway in most patients. For patients who have not sustained or are not suspected of having sustained spinal trauma, this simple maneuver is sometimes all that is needed for the patient to resume breathing. Follow these steps. With the patient supine, position yourself beside the patient's head, Place the heel of one hand on the patient's forehead and apply firm backward pressure with the palm. Place the tips of the other hand under the patient's lower jaw. Lift the chin upward with the entire lower jaw, helping to tilt the head back. Follow these steps. With the patient supine or on their back, position yourself behind or beside the patient's head. Place the heel on one hand of the patient's forehead and apply firm backward pressure with the palm. Place the fingertips of the other hand under the patient's lower jaw and lift the chin upward with the entire lower jaw, helping to tilt the head back. If you suspect cervical spine injury, use the jaw thrust maneuver. Follow these steps. Kneel above the patient's head. Place your fingers behind the angles of the lower jaw. Move the jaw upward and use your thumbs to help position the lower jaw. Once the airway has been opened, assess whether breathing has returned by quickly looking at the chest and observing for obvious movement. With complete airway obstruction, there will be no movement of air. The chest and abdomen may rise and fall with the patient's frantic attempts to breathe, so chest wall movement alone does not indicate that breathing is adequate. Even if the airway is opened, the mouth may still be closed. To open the mouth, place the tips of your index finger and thumb on the patient's teeth. Open the mouth by pushing your thumb on the lower teeth and index finger on the upper teeth. The pushing motion will cause the index finger and thumb to cross over each other, which is why it is called the cross finger technique. The photo on this slide demonstrates how to perform the jaw thrust maneuver. Kneeling above the patient's head, place your finger behind the angles of the lower jaw. Move the jaw upward. Use your thumbs to help position the lower jaw. This completed maneuver should look like the second photo. Portable, hand-operated, and fixed or mounted equipment is essential for resuscitation. A portable suctioning unit must provide enough vacuum pressure and flow to allow you to suction and mouth and nose effectively. A fixed suctioning unit should generate airflow of more than 40 liters per minute and a vacuum of more than 300 milligrams of mercury when the tubing is clamped. Hand-operated suctioning units with disposable chambers are reliable, effective, and relatively inexpensive. You may have a portable suctioning unit but it must provide enough vacuum pressure and flow to allow you to suction the mouth and nose effectively. A portable or fixed unit should be fitted with the following: wide-bore, thick-walled, non-kinking tubing, plastic rigid pharyngeal suction tips called tonsil tips or Youngkower tips, non-rigid plastic catheters called French or whistle tip catheters, a non-breakable disposable collection bottle, and water supply for rinsing the tips. A suction catheter is a hollow cylindrical device used to remove fluids from the airway. A tonsil tip catheter is the best kind of catheter for infants and children. The large diameter plastic tips are rigid and do not collapse. Tips with a curved contour should allow for easy, rapid replacement in the oral pharynx. French or whistle tip catheters are soft plastic, non-rigid catheters, and these are used to suction the nose and liquid secretions in the back of the mouth in situations when you cannot use a rigid catheter. This is, for example, like a patient who has a stoma, a patient with clenched teeth, or if suctioning of the nose is necessary. Before inserting a catheter, measure for the proper size. Use the same technique as measuring for an oropharyngeal airway. Do not touch the back of the airway with a suction catheter. This can activate the gag reflex, causing vomiting and increase the possibility of aspiration. Inspect your equipment regularly. To operate the suction unit, you want to check for proper assembly of its parts. Test the suctioning unit to make sure that it has pressure of more than 300 milligrams of mercury, and select and attach the appropriate suction catheter to the tubing as I was just explaining. Never suction the mouth or nose for more than 15 seconds at one time for an adult patient, 10 seconds for children, and 5 seconds for infants. Over-suctioning can result in hypoxia. Make sure to rinse the catheter and tubing with water to prevent clogging, and repeat suctioning only after the patient has been adequately ventilated and reoxygenated. You'll be able to practice this skill on skill drill 10-3. Sometimes the patient may have secretions or vomitus that cannot be suctioned quickly and easily, and some units cannot remove objects such as teeth, foreign bodies, and food. In these cases, remove the catheter from the patient's mouth, log roll the patient onto one side, and clear the mouth carefully with a gloved finger. If the patient requires assisted ventilations and is producing frothy secretions as quickly as you can suction them, suction the airway for 15 seconds, less in infants and children, ventilate for 2 minutes, and continue this alternating pattern of suctioning and ventilating until all secretions have been cleared from the airway. Continuous ventilation is not appropriate if vomitus or other particles are present in the airway. Clean and decontaminate your suctioning equipment after each use. There are different types of basic airway adjuncts that you can use. These help prevent obstruction by the tongue and allow for passage of air and oxygen to the lungs. The first one we're going to discuss are oropharyngeal airways. These keep the tongue from blocking the upper airway and make it easier to suction the oropharynx if necessary. Suctioning is possible through an opening down the center or along either side of the oropharyngeal airway. Indications for use of an oropharyngeal airway are unresponsive patients without a gag reflex who are breathing or apneic patients who are being ventilated with a BVM. Contraindications are patients who are conscious, or any patient conscious or unconscious who has an intact gag reflex. The gag reflex is a protective reflex mechanism that keeps food from entering the airway. Attempting to insert an oral airway in a patient with an intact gag reflex may result in vomiting or spasm of the vocal cords. An oral airway is a good way to help maintain the airway of a spinal injury patient. An oral airway may make the head tilt, chin lift, and jaw thrust maneuvers easier to perform. An oral airway that's too large could push the tongue back into the pharynx, blocking the airway, so make sure to measure it correctly. An oral airway that's too small could block the airway directly, like a regular foreign body obstruction. So to practice this and be able to insert them properly and measure them properly, you will practice this in skill 10-4. If you encounter difficulty inserting the oral airway, there is an alternative method that may be used, inserting with a 90-degree rotation, and you'll see that in skill drill 10-5. Now we're going to discuss nasopharyngeal airways. The indications are a patient who's unresponsive or has an altered level of consciousness, a patient who has an intact gag reflex, or a patient who is unable to maintain his or her own airway spontaneously. Indications for use of a nasopharyngeal airway are a semi-conscious or unconscious patient with an intact gag reflex, or a patient who will otherwise not tolerate an oropharyngeal airway. Contraindications are severe head injury with blood draining from the nose or a history of fractured nasal bone. To ensure the airway correctly, you'll practice this in skill drill 10-6. Now, maintaining the airway. The recovery position is used to help maintain a clear airway in an unconscious patient who is not injured and is breathing on his or her own with a normal respiratory rate and adequate tidal volume or depth of breathing. The steps to put the patient in an airway position are as follows. Roll the patient onto either side so the head, shoulders, and torso move at the same time without twisting. Extend the patient's lower arm and place the upper hand under his or her cheek. For patients who have resumed spontaneous breathing after being resuscitated, the recovery position will prevent aspirations of vomitus. This position is not appropriate for patients with suspected spinal, hip, or pelvic injuries who are unconscious and require ventilatory assistance. Reposition such patients to provide adequate airway access while maintaining appropriate spinal immobilization. Now let's discuss supplemental oxygen. Always give supplemental oxygen to patients who are hypoxic, because not enough oxygen is being supplied to the tissues and cells of the body. Some tissues and organs, such as the heart, central nervous system, lungs, kidneys, and liver, need a constant supply of oxygen to function normally. Never withhold oxygen from any patient who might benefit from it, especially if you must assist ventilations. When ventilating any patient in cardiac or respiratory arrest, use high concentration supplemental oxygen. Let's discuss supplemental oxygen equipment. You must become familiar with how oxygen is stored and the various hazards associated with its use. It comes in oxygen cylinders, and the oxygen that you give to patients is usually supplied as a compressed gas and is in a green seamless steel or aluminum cylinder. Some cylinders may be silver or chrome with a green area around the valve stem on the top. And newer cylinders are often made of aluminum or spun steel, while older cylinders are much heavier. Use of liquid oxygen is becoming a more commonly used alternative, but we'll talk about that in just a moment. You want to check that the cylinder is labeled for medical oxygen. Look for letters and numbers stamped into the metal on the collar of the cylinder. Check the month and year stamps indicating when the cylinder was last tested. And aluminum cylinders are tested every 5 years. Composite cylinders are tested every 3 years. Most often, the D or Jumbo D and M cylinder sizes are used and can be carried from the unit to the patient. The M tank remains on board as the main supply tank. There are other sizes, A, E, G, H, and K. In an alternative naming system for identifying the size of the oxygen cylinder, cylinders are labeled with M for medical, followed by a number. The length of time you can use an oxygen cylinder depends on the pressure in the cylinder and the flow rate. Now, liquid oxygen is becoming more commonly used as an alternative to compressed gas oxygen. Liquid oxygen containers tend to be more expensive than compressed oxygen tanks, hold a larger volume, and therefore do not need to be filled as often, weigh less than aluminum or steel tanks, need to be kept upright, and have special requirements for filling, large volume storage, and cylinder transfer. People who receive long-term oxygen therapy use liquid oxygen units. Now, safety considerations. Make sure to handle gas cylinders carefully because their contents are under pressure. Make sure the correct pressure regulator is firmly attached before transporting the cylinders. A puncture or hole in a tank can literally turn it into a deadly missile. So secure cylinders with mounting brackets when they are stored on the ambulance. Oxygen cylinders that are used during transport should be positioned correctly and secured. Now, the pin indexing system prevents such mistakes as an oxygen regulator being accidentally connected to a carbon dioxide cylinder. When preparing to administer oxygen, check that the pinholes on the cylinder exactly match the corresponding pins on the regulator. Each cylinder of a specific type of gas has a given pattern, given number of pins, following accepted national standards. For large cylinders, the safety system is the American Standard Safety System. Oxygen cylinders are equipped with threaded gas outlet valves. Inside and outside thread sizes vary depending on the gas in the cylinder. Like the pin indexing system, this prevents accidental attachment of a regulator to a wrong cylinder. Pressure regulators reduce the cylinder's pressure to a useful therapeutic range for the patient down to usually 40 to 70 psi. After the pressure is reduced to a workable level, final attachment for delivering the gas is one of the following. A quick connect female fitting that will accept a quick connect male plug from a pressure hose or ventilator/resuscitator, or a flow meter that will permit the regulated release of gas measured in liters per minute. Flow meters are usually permanently attached to pressure regulators on emergency medical equipment. A pressure compensated flow meter incorporates a float ball within a tapered calibrated tube. It is affected by gravity and must always be upright. The board and gauge flow meter is a gauge calibrated to record flow rate. It can be used in any position and is generally considered to be outdated. The major hazards of supplemental oxygen are combustion, and oxygen toxicity in the patient. Oxygen itself does not burn or explode, but it speeds up the combustion process. So any small spark or a glowing cigarette can become a flame. So keep any possible source of fire away from the area while oxygen is in use. Make sure the area is adequately ventilated, especially in industrial settings. Sparks during vehicle extrication are a possible source of ignition. So that's one thing to carefully consider. Never leave an oxygen cylinder standing unattended. It can be knocked over, injuring a patient or damaging equipment, or it can snap off the stem at the neck and turn into a missile. Oxygen toxicity is what we're going to discuss now, and the administration of oxygen to patients is a common practice. While many patients in the pre-hospital environment require high concentrations of oxygen, not all patients do. Excessive supplemental oxygen can have a detrimental effect on patients with certain illnesses, such as COPD or bronchopulmonary dysplasia. Oxygen toxicity refers to the damage to cellular tissue due to excessive oxygen levels in the blood. Increased cellular oxygen levels contribute to the production of oxygen-free radicals, which can lead to tissue damage and cellular death in some patients. The Internal Liaison Committee on Resuscitation Guidelines, published by the American Heart Association, recognize there may be negative effects of oxygen toxicity and recommend that oxygen be administered to patients experiencing signs of myocardial infarction when they have signs of heart failure, are short of breath, or have room air oxygen saturation less than 94%. Patients experiencing signs of shock should absolutely be placed on oxygen because hypoxemia is much worse than oxygen toxicity. So when in doubt or if unable to measure oxygen saturation reliably, supplemental oxygen should be administered. When pulse oximetry is available, tailor oxygen therapy to the patient's needs and administer the minimum amount of oxygen necessary to maintain oxygen saturation at or above 94%. Exceptions to these minimums include patients who have been exposed to carbon monoxide. Now we're going to talk about oxygen delivery equipment. In general, oxygen delivery equipment used in the field should be limited to non-rebreathing masks, BVMs, and nasal cannulas. You may encounter other devices during transports between medical facilities. Non-rebreathing masks are the preferred way to give oxygen in a pre-hospital setting to patients who are breathing adequately but are suspected of having or showing signs of hypoxia. With a good mask-to-face seal, such a mask is capable of providing up to 90% inspired oxygen. It combines a mask with a reservoir bag system. The oxygen fills a reservoir long attached to the mask by a one-way valve. Exhaled gas escapes through the flapper valve ports at the cheek areas of the mask. This prevents the patient from rebreathing exhaled gases. Make sure the reservoir bag is full before placing the mask on the patient. As I was just saying, make sure the reservoir bag is full before placing the mask on the patient. Then adjust the flow rate so the bag does not collapse when the patient inhales. Usually the flow is 10 to 15 liters per minute. If the bag does not collapse, increase the flow rate. When oxygen therapy is discontinued, remove the mask from the patient's face. And use a non-pediatric rebreathing mask for infants and children. Nasal cannulas deliver oxygen through two small tube-like prongs that fit into the patient's nostrils. It can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. For patient comfort, flow rates using a nasal cannula above 6 liters per minute are not recommended. When you anticipate a long transport time, consider using humidification. Over a prolonged period, a nasal cannula can dry or irritate the mucous membrane lining of the nose. As I was just saying, make sure to use humidification for a long transport time. And nasal cannulas in the pre-hospital setting have a limited use. They're generally used for a patient who breathes through the mouth or for a patient who is breathing through the mouth or has a nasal obstruction or will get little or no benefit, a nasal cannula is not recommended. Always try to give high flow oxygen through a non-rebreathing mask if you encounter such obstacles. Partial rebreathing masks are similar to non-rebreathing masks, except there's no one-way valve between the mask and the reservoir. Patients end up rebreathing a small amount of their exhaled air. This is advantageous if the patient is hyperventilating. The oxygen enriches the air mixture so patients receive 80 to 90% oxygen. To convert a non-rebreathing mask to a partial rebreathing mask, remove the one-way valve between the mask and the reservoir bag. Then there are Venturi masks. There are a number of attachments that can vary the percentage of oxygen while a constant flow is maintained from the regulator. The Venturi principle causes air to be drawn into the flow of oxygen as it passes a hole in the line. The Venturi mask is a medium flow device that delivers 24 to 40% oxygen depending on the manufacturer. This is useful in long-term management of physiologically stable patients. Then there are tracheostomy masks. Patients with tracheostomies do not breathe through their mouth and nose. The tracheostomy mask covers the tracheostomy hole and has a strap that goes around the neck. These may not be available in the emergency setting, in which case you should improvise by placing a face mask over the stoma in the neck. Although the mask is shaped to fit the face, you can usually get an adequate fit over the patient's neck by adjusting the strap. This is what I was just talking about. Make sure you remember that the tracheostomy mask covers the hole or stoma in the neck and has a stoma that goes around or strap that goes around the back of the neck. These aren't always available, but you can use a face mask placed at the tracheostomy opening. Now with humidification, some EMS systems provide humidified oxygen. This is used for extended transport and for certain conditions such as croup. Dry oxygen is not considered harmful for short-term use. Many EMS systems do not use humidified oxygen in the pre-hospital setting. Refer to medical control or local protocols for guidance in involving patient treatment issues. Now we're going to discuss assisted and artificial ventilation. Assisted and artificial ventilation techniques are probably the most important skills at EMS level, at any EMS level. Basic airway and ventilation techniques are extremely effective when administered properly, so mastery of these techniques at the EMT level is imperative. Patients who are breathing inadequately, too fast or too slow, with reduced tidal volume, are usually unable to speak in complete sentences. Fast, shallow breathing can be just as dangerous as very slow breathing. Follow standard precautions as needed when managing a patient's airway. Assisting ventilation in respiratory distress or failure. Make sure to intervene quickly to prevent further deterioration. Two treatment options are assisted ventilation and CPAP. The purpose of assisted ventilations is to improve the overall oxygenation and ventilatory status of the patient. Signs and symptoms of inadequate ventilation are altered mental status, inadequate minute volume, or excessive accessory muscle use and fatigue. To assist a patient with ventilations using a BVM, explain the procedure to the patient if they're conscious, place the mask over the patient's nose and mouth, squeeze the bag each time the patient breathes, maintaining the same rate as the patient. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume. Adjust the rate and tidal volume to maintain an adequate minute volume. Patients in respiratory arrest need immediate treatment to live. Once you determine a patient is not breathing, begin artificial ventilations immediately. Available methods are mouth-to-mask technique, 1 or 2 person BVM, or a manually triggered ventilation device. Let's talk about normal ventilation versus positive pressure ventilation. Artificial ventilations are necessary to sustain life, but are not as the same as normal breathing. In normal breathing, the diaphragm contracts and negative pressure is generated in the chest cavity, which sucks air into the chest. Positive pressure ventilation generated by a device forces air into the chest cavity. With positive pressure ventilation, there's increased intrathoracic pressure, causes compression of the vena cava, and reduces blood return to the heart, which reduces the amount of blood pumped by the heart. More volume is required to have the same effects as normal breathing, which pushes the airway walls out of their normal anatomic shape. Air is forced into the stomach, causing gastric distension that could result in vomiting and aspiration. The EMT must regulate the rate and volume of artificial ventilations to help prevent the drop in cardiac output. Cardiac output equals stroke volume times heart rate. Ventilation rates for apneic patients with a pulse are adults 1 breath every 5 to 6 seconds, a child 1 breath every 3 to 5 seconds, or an infant 1 breath every 3 to 5 seconds. Now we're going to discuss mouth-to-mouth and mouth-to-mask ventilation. A barrier device is routinely used in mouth-to-mouth ventilations. A plastic barrier is placed on the patient's face that includes a one-way valve to prevent the backflow of secretions, vomitus, and gases. Mouth-to-mouth ventilations without a barrier device should be provided only in extreme situations. A mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation. This supplements the air supplied by your lungs, which is approximately 16% every time you exhale. With the mouth-to-mask system, patients get the benefit of significant oxygen enrichment. This system both frees both of the EMT's hands to help keep the airway open and provides a better seal between the mask and face. To provide mouth-to-mask ventilation, you'll practice this in Skill 10-8. Signs of adequate ventilation are that the patient's color improves, the chest rises adequately, no resistance when ventilating, and you hear and feel air every time the patient exhales. To increase oxygen concentration, administer high-flow oxygen at 15 liters per minute through the oxygen inlet valve of the mask. Combined with your exhaled breath, this will deliver about 55% oxygen. The bag valve mask is the most common method used to ventilate patients in the field. It provides less tidal volume at a rate of roughly 15 liters per minute. It can deliver nearly 100% oxygen, however, but that's only as much volume as you can squeeze by hand. The BVM provides less tidal volume than mouth-to-mask ventilation, but delivers a much higher concentration of oxygen. An experienced EMT can provide adequate tidal volume. As a new EMT, develop proficiency by ventilating airway training mannequins before using a BVM on a patient. If you have difficulty adequately ventilating a patient with a BVM, switch immediately to another method, such as mouth-to-mask technique. The BVM components are a disposable self-refueling bag with no pop-off valve or a disabled pop-off valve, non-rebreathing outlet valve, oxygen reservoir that allows for use of high concentration oxygen, a one-way no-jam inlet valve with a flow of up to 15 liters per minute, and a transparent face mask. It offers the capacity of performing under extreme heat or cold conditions. And the total volume for adults that it provides is 1,200 to 1,600 milliliters. Pediatric is 500 to 700 milliliters. Infants are 150 to 240 milliliters. The volume of oxygen delivered is based on observing chest rise and fall. The only means of assessing tidal volume in the field is when using a BVM with high flow oxygen on an adult patient. Squeeze the bag just enough to cause a noticeable rise of the patient's chest, which is roughly 600 milliliters per second. By delivering just enough tidal volume to see the chest rise, it reduces the risk of gastric distension and associated complications from gastric distension. It is impractical for EMTs to accurately measure tidal volume in millimeters per kilogram in the field. The key to watch for is a good chest rise and fall, and let this determine the appropriate amount of volume to deliver. So BVM technique. Whenever possible, work together with your partner to provide BVM ventilation. One EMT maintains good mask safety seal by securing the mask to the patient's face with 2 hands. The other EMT squeezes the bag. To use the one-person BVM technique, follow these steps. Select the proper size mask and assemble your equipment. Kneel above the patient's head. Maintain the patient's neck in an extended position unless you suspect cervical spine injury. For a cervical spine injury, stabilize the patient's head and neck and use the jaw thrust maneuver. You can use your knees to stabilize the head. Open the patient's mouth. Suction as needed. Insert an oral or nasal airway to maintain airway patency. Place the mask on the patient's face. Make sure the top is over the bridge of the nose and the bottom is in the groove between the lower lip and the chin. If the mask has a large round cuff around the ventilation port, center the port over the patient's mouth. Inflate the collar for a better fit and seal to the face if necessary. Create a seal by holding your index finger over the part of the mask and your thumb over the lower part of the mask and your thumb over the upper part of the mask. Let me repeat that. Create a seal by holding your index finger over the lower part of the mask and your thumb over the upper part of the mask. Use your remaining 3 fingers to pull the lower jaw into the mask. This is called the EC clamp method. To bring the lower jaw up to the mask with the last 3 fingers of your hand, as I just explained, and this helps to maintain the open airway. Squeeze the bag with your other hand until you see adequate chest rise. Perform this in a rhythmic manner once every 5 seconds for adult, once every 3 seconds for infants and children. In patients with ongoing CPR and an advanced airway in place, such as an endotracheal tube, a laryngeal mask airway, or a King airway, use simplified ventilation of 1 breath every 6 seconds without pausing chest compressions. If 2 EMTs are available, follow these steps. One EMT holds the mask in position by placing the thumbs over the top of the mask and the index fingers over the bottom half. The first EMT uses the last 3 fingers of their hands to bring the lower jaw up to the mask. This helps to seal the mask to the face and maintain an open airway. The second EMT squeezes the bag with 2 hands until the chest rises adequately in the same manner as the one rescuer technique. For a patient who's breathing too slowly, hypoventilation with reduced tidal volume, squeeze the bag as the patient tries to breathe in. For the next 5 to 10 breaths, slowly adjust the rate and delivered tidal volume until adequate minute volume is achieved. For a patient who's breathing too fast, which is hyperventilation with reduced tidal volume, explain the procedure to the patient if the patient is coherent. Initially assess respirations at the rate the patient has been breathing, squeezing the bag each time the patient inhales. For the next 5 to 10 breaths, slowly adjust the rate and deliver tidal volume until an adequate minute volume is achieved. If the patient's chest does not rise and fall, you may need to reposition the head or use an airway adjunct. If the patient's chest still does not rise and fall after you've made these corrections, check for an airway obstruction. If an obstruction is not present, attempt ventilation using an alternate method such as the mouth-to-mask technique. The BVM may be used in conjunction with an endotracheal tube or other advanced airway techniques. Gastric distension. When using a BVM or other ventilation device, be alert for gastric distension, which is inflation of the stomach with air. It most commonly affects children, but it can affect adults. It's most likely to occur when you ventilate the patient too forcefully or too rapidly with a BVM or pocket mask, and may occur when the airway is obstructed as a result of a foreign body or improper head position. For this reason, give slow, gentle breaths during artificial ventilation over 1 second. As its compliance decreases, you will notice it becoming increasingly difficult to squeeze the BVM to get air into the lungs. Slight gastric distension is not of concern. Severe inflation of the stomach, however, is dangerous. It may cause vomiting and increase aspiration risk during CPR and can significantly reduce lung volume by elevating the diaphragm, especially in infants and children. Gastric distension is a common complication with manually triggered ventilation devices. This is a key reason these devices are not highly recommended. So to prevent or alleviate distension, ensure that the patient's airway is appropriately positioned, ventilate the patient at this appropriate rate, ventilate the patient with the appropriate rate, and if the patient's stomach appears to be distending, recheck and reposition the head and watch for rise and fall in the chest wall as you perform rescue breathing. Continue slow breaths or slow rescue breathing without attempting to expel stomach contents. If gastric distension makes it impossible to ventilate the patient and an ALS provider is not available to perform decompression, consider applying pressure over the upper abdomen, but that is a last resort. If vomiting occurs as a result, turn the patient's potty to the side, suction and or wipe out the mouth with your gloved hand, and return the patient to a supine position and continue rescue breathing. It's also important to understand that the bacteria in the stomach, the lungs cannot handle. So even if you clear the airway, if they've aspirated any of that vomitus, they can develop very deadly pneumonia. So it's another reason to make sure that you do not produce gastric distension. The process of expansion and contraction with passive ventilation is the contraction of the chest, which creates a quote-unquote pump for air movement in and out of the chest. During cardiac arrest, you're responsible for providing chest compressions to circulate blood and artificial ventilations to oxygenate the hemoglobin. Since the chest wall movement assists in the ventilation process, patients receiving high-quality chest compressions benefit from passive ventilation. In passive ventilation, air movement goes in and out of the chest cavity, and it occurs passively as a result of compressing the chest. When the chest is compressed, air is forced out of the thorax. As the chest recoils following compression, a negative pressure is created within its chest, which results in a vacuum. Air is sucked into the chest cavity, similar to what occurs with muscle contraction during active inhalation. Passive ventilation can be enhanced by inserting an oropharyngeal airway and providing supplemental oxygen to the patient. You can also improve oxygenation by applying supplemental oxygen with a nasal cannula or a non-rebreathing mask. There are manually triggered ventilation devices. These are also known as flow-restricted, oxygen-powered ventilation devices. They allow a single rescuer to use both hands to maintain a mask two-phase seal while providing positive pressure ventilation. This reduces rescuer fatigue associated with using a BVM on extended transports. Some disadvantages of a manually triggered ventilation device are that it may be difficult to maintain adequate ventilation without assistance, should not be used routinely because of high incidence of gastric distension and possible damage to structures within the chest cavity. Special unit and additional training are required for infants and children, and it should not be used on patients with COPD or suspected cervical spine or chest injuries. The manually triggered ventilation device components are that they provide a peak flow rate of 100% oxygen at up to 40 liters per minute. They have an inspiratory pressure safety relief valve, an audible alarm that sounds when you exceed relief valve pressure, the ability to function satisfactorily under normal and varying environmental conditions, and a trigger or lever position so that both your hands can remain on the mask to provide an airtight seal while supporting and tilting the patient's head to keep the jaw elevated. Proper training and considerable practice are required. As with a BVM, you must make sure there's an effective seal between the patient's mask and face. The amount of pressure required varies according to patient size, lung volume, and lung condition. A COPD patient will need greater pressure, which is one reason that it's not really recommended, and pressures that are too great can also cause a pneumothorax. There are automatic transport ventilators or resuscitators. The ATV is the acronym that's commonly used and is a manually triggered ventilation device attached to a control box that allows the variables of ventilation to be set. It does lack the sophisticated control of a hospital ventilator, however, but it does free the EMT to perform tasks such as maintaining the mask seal or ensure continued patient airway patency. A BVM and mask should always be prepared and ready for use should an ATV malfunction. Most models have adjustments for respiratory and tidal volume. The estimate tidal volume should be 6 to 7 milliliters per kilogram. The pressure relief valve may lead to hypoventilation in patients with poor lung compliance, which is the ability of alveoli to expand when air is drawn in during inhalation, increased airway resistance, or airway obstruction. Constant reassessment of the patient is necessary. So assess for full chest recoil. Now, let's talk about continued positive airway pressure, or CPAP, which is a non-invasive ventilatory support for patients experiencing respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night to maintain their airways while they sleep. CPAP is also becoming widely used at the EMT level. The mechanism for CPAP is as follows. The CPAP increases pressure in the lungs, opens collapsed alveoli, pushes more oxygen across the alveolar membrane, and forces interstitial fluid back into pulmonary circulation. The therapy is typically designed to be delivered through a face mask held to the head with a strapping system. A good seal with minimal leakage between the mask and the face is essential. Many CPAP systems use oxygen as the driving force to deliver the positive ventilatory pressure to the patient. Use caution with patients with potentially low blood pressure because CPAP causes a drop in cardiac output. Indications for CPAP are if the patient is alert and able to follow commands, if the patient displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or obstructive pulmonary disease such as COPD, if the patient is breathing rapidly such that it affects overall minute volume, which is greater than 26 breaths per minute, or the pulse oximetry reading is less than 90%. Contraindications for CPAP are a patient who's in respiratory arrest, shows signs and symptoms of pneumothorax or chest trauma, patient who has had a tracheostomy, active gastrointestinal bleeding or vomiting, a patient who's unable to follow verbal commands, and then always reassess the patient for signs of deterioration and or respiratory failure. The components of a CPAP unit consist of a generator, mask, a circuit containing corrugated tubing, bacteria filter, and a one-way valve. The CPAP generator creates resistance through the respiratory cycle. This resistance creates a back pressure into the airways that pushes open the smaller airway structures such as bronchioles and alveoli as the patient exhales. The amount of pressure can be determined by adjusting a valve within the CPAP system with a separate valve or with a separate valve that can be attached. A pressure of 7 to 10 centimeters of H2O is generally accepted as a therapeutic range. Most CPAP units are powered by oxygen, so it is important to have a full cylinder of oxygen when using a CPAP. Disposable CPAP devices are lightweight and relatively easy to operate. And to use a CPAP, you'll practice this during skill drill 10-10. There can be complications from a CPAP. Some patients may find CPAP claustrophobic and resist application of the mask. You have to coach patients through the process rather than forcing the mask on them. Due to the high volume of pressure created by CPAP, pneumothorax is a risk. High pressure in the chest can lower the patient's blood pressure. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using BVM attached to high-flow oxygen. Special considerations are stomas and tracheostomy tubes. Patients who've had a laryngectomy or surgical removal of the larynx have a permanent tracheal stoma, which is an opening in the neck that connects the trachea directly to the skin. This is known as a tracheostomy. Patients may have other openings in the neck depending on the type of operation they've had performed. Ignore any opening other than the midline tracheal stoma. It is the only one that can be used to put air into the patient's lung. Neither the head tilt or chin lift maneuver nor the jaw thrust maneuver is required to ventilate a patient with a stoma. If the patient has a tracheostomy tube, ventilate through the tracheostomy tube with a BVM. A standard 15 to 22 millimeter adapter on the BVM will fit onto the tube in the tracheal stoma. Use 100% oxygen attached directly to that BVM. If the patient has a stoma stoma but no tube is in place, use an infant or child mask with your BVM to make a seal over the stoma. If the patient has a stoma but no tube is in place, use an infant or child mask with your BVM to make a seal over the stoma, as I just said. Seal the patient's mouth and nose with one hand to prevent a leak of air through the upper airway when you ventilate through the stoma, and release the seal of the patient's mouth and nose for exhalation. This allows the air to escape through the upper airway while maintaining a seal over the stoma. If you cannot ventilate a patient with a stoma, try suctioning the stoma and the mouth with a French or soft tip catheter. Seal the stoma while giving mouth-to-mouth ventilation. In an adult, sudden foreign body airway obstruction usually occurs during a meal, and if there's total obstruction, it is a dire emergency. In a child, it can occur while eating, playing with small toys, or crawling around the house. By far, the most common airway obstruction in an unconscious patient is the tongue, which relaxes and falls back into the throat. The causes of airway obstruction that do not involve foreign objects include swelling from infection or acute allergic reaction. So repeated attempts to clear the airway could be dangerous because you can exaggerate swelling. These patients require specific emergency medical care, so rapid transport to the hospital is critical. Or they could have trauma or tissue damage from injury, such as an automobile accident. Early recognition of airway obstruction is critical. For mild airway obstruction, you'll have patients that can still exchange air but will have varying degrees of respiratory distress. Great care must be taken to prevent a mild airway obstruction from becoming a severe airway obstruction. The patient may have noisy breathing and may be coughing. With good air exchange, the patient can cough forcefully, although you may hear wheezing between coughs or the production of whistling sounds during respirations. Wheezing usually indicates a mild lower airway obstruction. As long as the patient can breathe, cough forcefully, or talk, you should not interfere with the patient's efforts to expel a foreign object on his or her own. Continually reassess the patient's condition. With poor air exchange, the patient has a weak, ineffective, or not very forceful cough and may have increased difficulty breathing, or stridor, which is high-pitched noise heard mainly on inspiration, and cyanosis. Stridor indicates mild upper airway obstruction and needs to be treated immediately as if there is a severe airway obstruction. For severe airway obstruction, patients cannot breathe, talk, or cough. The patient may use what's become known as a universal distress symbol, where they clutch or grasp their throat and they begin to turn cyanotic and have extreme difficulty breathing. There is little or no air movement, so ask the conscious patient, "Are you choking?" If the patient nods yes, provide immediate treatment. If the obstruction is not cleared quickly, the amount of oxygen in the patient's blood will decrease dramatically, and if not treated, the patient will become unconscious and die. Some patients will be unconscious as you form your general impression. You may not know that there's an airway obstruction that is the cause. Emergency medical care for foreign body obstructions are to perform a head tilt chin lift maneuver to clear tongue obstruction. If spinal trauma is suspected, open the airway with a jaw thrust maneuver. Large pieces of vomited food, mucus, loose dentures, or blood clots in the mouth should be swept forward and out of the mouth with your gloved index finger. When available, perform suctioning to maintain a clear airway. Abdominal thrust is the most effective method of dislodging and forcing an object out of the airway of a conscious patient. Residual air, always present in the lungs, is compressed upward and used to expel the object. Use abdominal thrust until the object dislodges or the patient becomes unconscious. For the unresponsive patient with a severe foreign body airway obstruction, reassess to confirm apnea and inability to ventilate. There are many things that can cause airway obstruction that are dental appliances. Many dental appliances can cause an airway obstruction, such as the crown, bridge, dentures, or piece of braces. Manually remove the dental appliance before providing ventilations. Simple manual removal may relieve the obstruction and allow the patient to breathe on his or her own. Leaving well-fitting dentures in place usually makes a BVM or mouth-to-mask ventilation much easier. Be cautious that dental appliances may loosen while you're providing care. So periodically reassess the patient's mouth to make sure they're firmly in place. If possible, place dislodged dentures into a container and transport them with the patient. Now, there are airway problems that can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich, so injuries can result in severe tissue swelling and bleeding into the airway. Control bleeding with direct pressure and suction as necessary. This is a very difficult chapter class with a lot of detail, so please make sure that you study or study up with a partner, review anatomy and physiology, review the mechanics of breathing, review the chemistry of breathing, and then make sure you practice the skills for opening, clearing, maintaining a patent airway in the patient. So let's do the review questions now. Number 1, breathing is controlled by an area in the lungs, brainstem, spinal cord, and diaphragm. And I said this one specifically, so you should remember it. The answer is B. The pons and medulla are the respiratory centers in the brainstem that control breathing. So let's look at the wrong answers. Breathing is controlled by an area in the lungs. That's incorrect. The lungs contain the small pockets called the alveoli where you have the gas exchange between oxygen and carbon dioxide. B is the brainstem, like we just said. The spinal cord impulses are sent down the spinal cord from the brainstem. The brainstem sits at the top of the spinal cord and is really the adjunct between the brain and the spinal cord itself. The diaphragm receives impulses from the brainstem that cause it to contract and bring air in. So the correct answer is brainstem. Number 2, the EMT should assess a patient's tidal volume by A, observing for adequate chest rise, B, assessing the facial areas for cyanosis, or C, counting the patient's respiratory rate, or measuring the patient's oxygen saturation. This one's easy. I said it about 20 times during the slides that were previous. And it is A, tidal volume. The volume of air that's moved into or out of the lungs in a single breath. It's assessed by observing for adequate chest rise. If shallow chest rise is noted, the patient's tidal volume is likely reduced. Remember, their chest is going to rise, just generously enough to fill it up. But if you don't see any, or you see minimal chest rise, then they could have lowered tidal volume. So let's look at the incorrect answers. B, the EMT should assess the patient's tidal volume by assessing the facial area for cyanosis. That's an indication of hypoxia, not tidal volume. C, counting the patient's respiratory rate. That only gives you minute volume, or the number of times a patient breathes in 1 minute. Doesn't tell you tidal volume. It only tells you the rate. Or D, measuring the patient's oxygen saturation. That's an indication of tissue perfusion, which is the amount of oxygen attached to the hemoglobin. It has nothing to do with tidal volume. Tidal volume is chest rise, adequate chest rise. 3, in an otherwise healthy individual, the primary stimulus to breathe is A, an increased level of oxygen in the blood, B, a decreased level of oxygen in the blood, C, increased level of carbon dioxide in the blood, or D, decreased level of carbon dioxide in the blood. If you think about the basic mechanics and gas exchange, this one should be pretty easy. And it is C. Under control of the brainstem, rising levels of the carbon dioxide in arterial blood normally stimulate breathing in an otherwise healthy patient. So let's look at the incorrect answers. In an otherwise healthy individual, the primary stimulus to breathe is an increased level of oxygen in the blood. That's not the stimulus to breathe. The increased levels of oxygen can be a result of hyperventilation. Decreased level of oxygen in the blood. That's typically not normal in healthy individuals. It can be a sign of inadequate breathing and results in hypoxia. So it's not a stimulus to breathe. C is the high level of carbon dioxide in the blood. The brainstem recognizes that, causes inspiration to cease and exhalation to occur, and then you continue breathing. Or D, decreased level of carbon dioxide in the blood. This is not seen normally in a healthy adult. It is typically a result of hyperventilation syndrome, so where they're getting too much oxygen. 4. Signs of adequate breathing in the adult include all the following except pink, warm, dry skin, shallow chest rise, symmetrical chest movement, or respiratory rate of 16 per minute. Remember, it's signs of adequate except one of these. And it is B. Signs of inadequate breathing in the adult include a respiratory rate less than 12 breaths per minute or greater than 20 breaths per minute, shallow chest rise, which is reduced tidal volume, cyanosis, and asymmetrical chest movement, where both sides of the chest do not move equally. So let's look at this closer. Signs of adequate breathing in the adult include all the following except A, pink, warm, dry skin. That's normal, and that shows that breathing and perfusion are adequate. It doesn't matter what color skin your patient has, how tan they are, or what color their skin is. You will notice if there's adequate blood flow or not. Everyone has pink from the hemoglobin in their skin, no matter what shade their skin is. And it is very clear when a patient is suffering from hypoxia or an inadequate perfusion. That pink color that underlies everyone's skin tone disappears. B, shallow chest rise. This is the correct answer. Signs of adequate breathing include all the following except shallow chest rise. That's going to indicate inadequate tidal volume. C, symmetrical chest movement. This shows that the mechanical process of breathing is adequate, equal, and symmetrical bilaterally. Well, that's normal. And D, a respiratory rate of 16 per minute. That's normal because adults breathe 12 to 20 breaths per minute. During insertion of an oropharyngeal airway into an unconscious patient, she begins to vomit. The first thing you should do is turn the patient on her side, B, remove the airway at once, C, suction the patient's mouth, or D, use a smaller sized oral airway. Answer is A. Whenever an unconscious patient begins to vomit, whether you are inserting an oropharyngeal airway or not, you should immediately turn the patient onto his or her side. Remember to log roll them to prevent twisting of the spine, and this will allow drainage of vomit from the mouth and prevent aspiration. After the patient is on his or her side, remove the oral airway and suction the mouth. So let's look at the wrong answers. Remove the airway at once. Remove the airway after the patient's been rolled onto their side. C, suction the patient's mouth. This must be done after the patient is positioned and the airway is removed. D, use a smaller sized oral airway. Oropharyngeal airways are contraindicated if the patient has a gag reflex. If you put in an oropharyngeal airway and the patient vomits, they have an active gag reflex. You're going to have to use a nasopharyngeal airway. In which of the following patients would a nasopharyngeal airway be contraindicated? In a semi-conscious patient with a gag reflex, an unconscious patient with an intact gag reflex, a patient who fell 20 feet and landed on his or her head, or an unconscious patient who gags when you insert an oral airway. So in which of the following would you not use a nasopharyngeal airway, or when would it be contraindicated? The answer is C. Nasopharyngeal or nasal airways are contraindicated in patients with severe head or facial injuries and should be used with caution in patients who have delicate nasal membranes or who are prone to nosebleeds. The nasal airway is better tolerated in patients who are semi-conscious and or those with a gag reflex. Number 6. In which of the following patients Would a nasopharyngeal airway be contraindicated? Let's look at the wrong answers. A semi-conscious patient with a gag reflex. Okay, that's fine. And a nasopharyngeal airway will work fine in a patient here. An unconscious patient with an intact gag reflex. Again, this is the one that works best if they have an intact gag reflex. C, the correct answer is someone who fell 20 feet and landed on his or her head. Nasopharyngeal airway would be contraindicated because they can have fracture between the skull and facial or facial bones, and you can actually end up sliding the airway into their brain, which is not a good thing. D, an unconscious patient who gags when you insert an oral airway. Again, if somebody gags with an oral airway, then you're going to use a nasopharyngeal airway. So all these patients, it would be fine except for C, the patient who fell 20 feet and landed on his or her head. If you are delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he begins to complain of a burning sensation in his nose, you should A, remove the nasal cannula, B, apply a non-rebreathing mask, C, attach an oxygen humidifier, or D, increase the flow rate to 6 liters per minute. Remember, the tank oxygen is dry compressed oxygen. So this answer should be very easy. And it is C. Administering dry oxygen through a nasal cannula, what comes over a tank, especially over a prolonged period of time, can result in drying of the nasal membranes, in which case the patient might complain of having a burning sensation of the nose. Humidified oxygen will help serve to keep nasal membranes moist. So let's look at the wrong answers. A, remove the nasal cannula. Nope, just humidify the oxygen. B, apply a non-rebreathing mask. That's incorrect because it can still cause an irritation because you're providing dry, non-moisturized oxygen straight from the tank. C, attach an oxygen humidifier. That's the correct answer. D, increase the flow rate to 6 liters per minute. That's not going to do anything except dry his nose out faster. So humidity is your answer here. 8, a patient is found unconscious after falling from a 3rd floor window. His respirations are slow and irregular. You should A, place him in the recovery position, B, apply oxygen via a non-rebreathing mask, C, suction his airway for up to 15 seconds, or assist his breathing with a bag mask device. Okay, think about the kinds of injuries they're going to have after falling from a 3rd floor window. So the correct answer is D. The patient is not breathing adequately. They have slow, irregular respirations and will not result in adequate oxygenation. You should assist the patient's breathing with a BVM mask attached to 100% oxygen, and suctioning is indicated if the patient has blood or other liquids in the airway, and there's no evidence of this in this particular scenario that was given to you in the question. However, also, you need to remember that when using the BVM, somebody that fell on the 3rd floor, they're very likely to have head and spinal injuries and fractures. So you want to make sure that you use jaw thrust maneuver and stabilize their spine. So let's look at the incorrect answers. A, place him in the recovery position. Like I said, look at the scenario. Due to significant MOI, the patient should be placed supine on a long backboard with the head immobilized. B, apply oxygen via a non-rebreathing mask. They don't have adequate respirations for that on their own, so a BVM device is indicated if the respirations are less than a minute. A non-rebreathing mask isn't going to do anything except supply oxygen to somebody who cannot actually breathe and process it on their own very well. C, suction his airway for up to 15 seconds. This is only indicated if a patient has blood or other secretions in the airway. In this particular question, this would have been wrong because that was not included in the scenario. And D was the correct answer. Assist his breathing with a BVM. Number 9, when ventilating an apneic adult with a bag valve mask, you should squeeze the bag A till it's empty, B over a period of 2 seconds, C at a rate of 20 breaths per minute, or D until visible chest rise is noted. So if you think back to all that information I gave you about BVMs, it's impossible to measure the milliliters per kilogram that you're giving them. So what are you actually looking for? D. When ventilating any apneic patient with a BVM, you should squeeze the bag over a period of 1 second and observe visible chest rise. Ventilate the apneic adult at a rate of 10 to 12 breaths per minute, or 1 breath every 5 seconds. Ventilate infants and children at a rate of 12 to 20 breaths per minute, 1 breath every 3 seconds. And again, you're just looking for adequate chest rise, not huge hyperextension of the chest. Then you're going to cause a pneumothorax. So it's just enough to provide adequate chest rise. Number 9, when ventilating an apneic adult with a BVM mask, you should squeeze the bag A till it's empty. That's incorrect because an appropriately sized bag for an adult will not totally empty. B, over a period of 2 seconds, you should squeeze the bag over a period of 1 second, not 2 seconds. C, at a rate of 20 breaths per minute. That's incorrect because it's 1 breath every 5 seconds. And D, until visible chest rise is noted. And as we reviewed, that is the correct answer. Number 10, you and your partner are ventilating an apneic adult when you notice that his stomach is becoming distended. You should A, suction his airway for up to 15 seconds, B, reposition his head, C, increase the rate and volume of your ventilations, and decrease your ventilation rate but use more volume. But think about this. We talked about the physiology at the very beginning of this chapter. The airway sits in front of the esophagus and is lower. The entrance of the airway is lower than that of the esophagus. So why are they getting gastric distension? You should now be able to figure out the answer. And it is B. Gastric distension occurs when air enters the stomach. Severe gastric distension can result in vomiting and aspiration if not recognized and treated. To minimize the amount of air that enters the stomach during ventilation, you should reposition the patient's head. So if you're ventilating and their stomach's getting bigger and bigger and bigger, then it's going straight into their esophagus. You don't have their head positioned correctly for air to enter the airway, which has a lower entrance in the front of the neck than that of the esophagus. So let's look at the incorrect answers. A, suction his airway for up to 15 seconds for somebody who has become distended in the stomach. Suctioning is only indicated when there are blood secretions in the upper airway or in the airway. B, reposition his head. That's the correct answer as we just discussed. C, increase the rate and volume of your ventilation. That's just going to produce even more air in the stomach because you don't have the head position right. Or D, decrease your ventilation rate but use more volume. That doesn't make any sense because that action is going to result in more air going to the stomach rate as well. So, thank you for your time and attention. This is a long and complicated chapter, like chapter 6 with anatomy and physiology, but it's crucial. This is your most important thing when encountering the patient is A, airway. So that's why we spent so much time and attention on it. It's important again that you review the physiology and anatomy of the respiratory system and have a good understanding of it. Review the basic chemistry of what's going on between oxygen and carbon dioxide, where that takes place. Make sure you review all the different adjuncts and breathing devices that are available. And thank you for your time and attention. We will see you next class.